Thank you for your participation, and thank you also for the opportunity to be present in this teaching session. I am a senior house officer that's working in emergency medicine. And today our topic is myocardial infarction and its complications. Okay, and this is also brought to you by Thriving in the NHS. All right, so what is myocardial infarction? Myocardial infarction is basically decreased or complete cessation of blood supply to a part of the myocardium. All right, it typically occurs from the rupture of an atherosclerotic plaque, which triggers a coagulation cascade. All right, and a thrombus then forms, leading to the constriction of a vessel or complete occlusion, and that results in inadequate blood and oxygen reaching that segment of the myocardium. And inadvertently, we have tissue death or infarction. Okay. A rarer cause of myocardial infarction is coronary spasm. All right. And this is called a variant angina or Prinzmetal angina. An acute occlusion of about 20 to 40 minutes is enough to cause acute myocardial infarction. And something that's important to know is that, unlike skin cells, for example, cardiac
It's frozen at my
myocytes,
end. I think something may have happened with Dr. Uku's feed. We'll just try and
Can you
let
still
her
hear
know.
me? Can you still hear me?
Yes, I can at my end.
Okay, you can hear at your
Okay.
end.
Yes, I can,
Oh,
ma'am.
sorry. Then it must be from me.
Okay.
Let me.
All right. Can you hear me? I don't know.
Please, I can.
All right. All right. I'm going to proceed. Okay. So, cardiac myocytes, they do not have regenerative capacity like, for example, skin cells. So what that means is they will have, when the cardiac myocytes die, okay, it will result in scar formation, okay, and that's going to cause a change in the structure of the heart. Basically, the heart will undergo cardiac remodeling, all right, which can be characterized by dilation or hypertrophy, and there would be changes in the cardiac conduction. We'll talk about this more as we go on. So, acute coronary syndrome. When we talk about acute coronary syndrome, we're typically referring to unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. So, unstable angina differs from stable angina, being that it is chest pain or angina that occurs at rest. All right. In unstable angina, you still have ischemia, but there is no necrosis. Okay, so the ischemic insult is not severe enough to cause necrosis. All right, and then in non-ST elevation myocardial infarction, there is necrosis, but it is partial. Whereas in ST elevation myocardial infarction, you have a transmural necrosis, meaning that it goes up the entire myocardium from the endocardium to the epicardium. Okay.
Sorry, Dr. Uche, can you please maybe move closer to your mic or just
Okay, you can't hear me. Is this better?
Yes, it's better now. Yeah, this is
Okay.
better.
All right, good. Right. So sorry for that. All right. So risk factors associated with ACS. Smoking is one of the major risk factors with acute coronary syndrome. Okay. Smoking has a prothrombotic effect. All right. So, and another major risk factor is abnormal lipid profile. Okay, we talked about the rupture of an atherosclerotic plaque. And one of the major components when it comes to atherosclerosis is high cholesterol deposits, right? So those are the major risk factors with ACS. Other risk factors are hypertension, diabetes, sedentary lifestyle, obesity, cocaine-induced ischemia. Cocaine-induced ischemia would cause the vasospastic angina that we refer to. Okay, and then you have non-modifiable causes like age, males over 45, and then females. So let's just move on. So complications. Now, complications, myocardial infarction can impair the diastolic and the systolic dysfunction. Okay, so you have an ischemic segment. That means that a part of the heart is not functional. All right, and that's going to lead to poor myocardial contractility. So the heart will be unable to contract as effectively as it used to. What that's going to cause is it's going to result in a decrease in the cardiac output, a reduction in the stroke volume, and a reduction in the blood pressure as well. Okay. Now, as much as there's the reduction in the stroke volume, so not enough blood is going out, it means that a lot of blood is staying in. So there's going to be an increase in the left ventricular end diastolic pressure. All right. So there's going to be a backup of blood into the pulmonary circulation, okay, which would cause pulmonary congestion and hypoxemia. So the patient may present dyspneic, okay, short of breath, right? And that's pulmonary congestion is the cause. With a loss or death in the cardiac myocytes, you're going to have a loss of conduction channels, all right? And that's going to cause a disruption in the electrical gradients, which would cause arrhythmias. The most common arrhythmias in myocardial infarctions are ventricular tachycardias and ventricular fibrillation, but you could also have atrial fibrillation, mitral regurgitation, and AV blocks. Okay. Other complications which we would discuss later on are things like reinfarction, cardiac rupture, either rupture of the ventricular septum or papillary muscle rupture, pericarditis, congestive heart failure, we sort of discussed that, pulmonary edema due to poor cardiac output, and pericardial effusion. Okay. So how would the patient present clinically? The patient may present with a retrosternal chest pain or a left-sided chest pain with or without radiation to the jaw, the neck, the left upper arm. And sometimes patients may have atypical chest pain or atypical presentations like epigastric pain, nausea, and vomiting. Diabetics, especially, and women have these atypical presentations where diabetic, because of the neuropathy, they don't have the typical chest pain. Okay, they might present with more of the autonomic symptoms, which we can see as diaphoresis, palpitations. There's also we talked about reduced cardiac output. That means there might be reduced blood flow to the cerebrum, and then patients may present with either pre-syncope or even have a syncopal episode. Okay. Investigations. So, good history, good physical examination. You don't really see much of physical examination, but we'll still go through each of them. So history, we can use Socrates. Site, we talked about the sites. Where is the pain? It's usually retrosternal, okay, or left-sided chest pain, all right? Or sometimes epigastric pain. Onsets, this is also important to know because of the management, all right? Character, what's the quality of the pain? What type of pain? How would they describe the pain? They can describe it as a heavy pressure-like sensation or even a constricting-like pain, all right? This can also help with the differential diagnosis as well, because, for example, if it's a tearing pain, you might be thinking more of an aortic dissection. If it's a pleuritic pain, you might be thinking more of pericarditis or pulmonary embolism. Radiation, we discussed that already. The upper arm, the jaw, the neck, associating symptoms. Typically, the associating symptoms are the autonomic symptoms, so the diaphoresis, the sweating. You see them, they're either pale. If they're hemodynamically unstable, you might see signs of shock. Time and duration, exacerbating or relieving factors. Is this a patient who has a known case of stable angina? Did they try taking nitroglycerin, and if it was effective or not? Nitroglycerin is typically not effective in ACS, okay? And severity, so like they can grade their pain, all right? Like a scale of 1 to 10, for example. And it's usually quite severe. So on physical examination, what you're going to see is patient may have this classic Levine sign where they're clutching their chest. Okay, they have a clenched fist to their sternum. You might see signs of cardiogenic shock, like cool peripheries, clammy skin, cyanotic lips, or hemodynamic instability. I've actually had a patient, all right, who presented, and her major symptom was an episode of a cyanotic lip. She didn't have an intermittent episode of chest pain, okay? At the time of presentation, she wasn't really having any chest discomfort, so it was a very atypical presentation. So it's also something to note. Also, so we said signs of shock: tachycardia, normal tension, hypotension. In the case of right ventricular dysfunction, you might see an elevated jugular venous pressure, okay? Or you might hear pulmonary crackles on auscultation as well, okay? So, what is the most important blood test to take for while you're investigating an acute coronary syndrome? Troponin, okay? Troponin has a high specificity for acute coronary syndrome because it's primarily only in the cardiac myocytes. Okay, so when the cells die, they release the troponin. And it's good to take serial tests of the troponin because troponin rises typically as early as 2 to 4 hours from symptom onset. Okay, but sometimes there might be a delay for about 8 to 12 hours. All right, so your initial troponin level may be in the negative or may not have a significant rise. So it's always good to take a second troponin, all right, to completely rule out or confirm an acute coronary syndrome. Okay, and then you have to look at the clinical vignette because there are other causes of troponin elevation, as we can see here. All right, so you have to associate that with chest pain or ECG signs and whatnot. Okay, so the full vignette paints a better picture for you. So there, as you can see, we said there are other causes of troponin elevation, which can be, like, for example, a hypertensive crisis, an acute pulmonary embolism, sepsis, even carbon monoxide poisoning. All right, so we're going to move on. All right, so here you have a normal ECG. All right, I hope we're familiar. P wave represents atrial depolarization. You have the QRS complex, which represents ventricular depolarization. You have the T wave, which represents ventricular repolarization. And you can see that the ST segment is on the isoelectric line, okay? So this is what your normal ECG should typically look like, all right? All right, what changes would you expect on your ECG? You're going to expect ST depression, especially when you're talking about non-ST elevation, acute coronary syndrome, okay? And then you can see ST elevation in a STEMI. You could also note hyperacute T waves or inverted T waves, pathological Q waves, and a new onset left bundle branch block, okay? Not a previously present LBB. There's the Esgar-Bose criteria as well, but we won't go into that because that's more detailed. So now here we have the ECG territories, okay? So you have to recall your anatomy for this segment. The left anterior descending coronary artery supplies the blood flow to the interventricular septum, to the anterolateral wall, and the ventricular apex. So we're talking about the leads V1 to V4, okay? And then the left circumflex artery supplies blood to the inferolateral wall, all right? So this is the lateral leads. Lead 1, AVL, V5 to V6. And the right coronary artery supplies the right ventricle, okay? These are the inferior leads, and this is leads 2, 3, and AVF, okay? So here we have hopefully a good diagram to show their representation. You can see that V1 to V4 are more anterior, okay? Showing that these are your anteroseptal leads. You can see that V4 is more at the apex. And then you have V5 to V6, which are your lateral leads as well. And then you can also see that they are placed laterally, all right? And then you can also see the territories on the ECG strip, okay? You can see leads 1, AVL inclusive, V5 and V6 are your lateral leads. Your anteroseptal leads are V1 to V4, and your inferior leads are 2, 3, and AVF, okay? All right, so here is a classic ECG strip showing ST elevation, okay? And we can see, as we've discussed, in leads 2, 3, and AVF, you have clear ST elevation, okay? And we said these are your inferior leads, okay? And you can see reciprocal changes in leads 1, okay, in leads V2, V3, and V6, and that's reciprocal changes in your anterolateral leads, okay? So both in the anterior and in the lateral leads as well. All right, I hope that's clear. And I hope I'm still being very audible as well. All right. So how do you manage?
Yes.
Okay. Thank you. Thank you for the confirmation. So how do you manage an acute coronary syndrome? So the general management for for acute coronary syndrome is intravenous morphine. So you want to address their pain. Your patient has presented with pain initially. So you address the pain, give them some intravenous morphine because it also calms them down as well. Okay. And then if the patient is nauseous or vomiting, you also want to address that as well because it's going to be very difficult to treat a patient who's constantly having to be sick. So you can give metoclopramide, but you want to be cautious with metoclopramide if the patient has Parkinson's, okay? Because you can have dystonic reactions, all right? And you want to be cautious in the young females, okay? Because they can also have dystonic reactions as well, all right? Tardive dyskinesia. In that case, you can give alternatives like ondansetron or cyclizine. Oxygen therapy should be supplied if the patient is not maintaining oxygen saturation above their target range. So typical target range is above 94, okay? But then if the patient has an obstructive lung disease, for example, like COPD, which they typically have a lower oxygen saturation target range, 88 to 92, all right? So if the patient is maintaining their baseline oxygen saturation, you no need to give further oxygen supplementation because some literature says that you can actually cause further damage because the oxygen is going to cause a release of free radicals, which can cause further insults to the heart. Okay, so nitrates. You can give nitrates as well, but you have to be cautious because nitrates cause venodilation, okay? And that can cause hypotension. All right, so if your patient is hemodynamically unstable, they're hypotensive, best to not give the nitrates, okay? But if they're hypertensive, as we said, they can either present normotensive, hypotensive, or hypertensive. If they are hypertensive, the blood pressure being high, you can give nitrates. To be best to give nitrates because it would increase the blood flow as much as it is bringing down the blood pressure. Dual antiplatelet therapy is a must, okay? That's a given. So you have to give them aspirin, loading dose of 300 milligrams, and then they continue on a maintenance dose of 75 milligrams. And dual antiplatelet therapy. So aspirin is a given, and then you have to give either clopidogrel or prasugrel or ticagrelor, okay? Depending on the patients and any comorbidities they may have or contraindications, okay? So what is the goal of treating ACS? Reperfusion is the goal when you're treating ACS, basically. You want to restore blood flow to that ischemic tissue, okay? Usually they say that reperfusion should occur within 12 hours of symptom onset because within 12 hours about 12 hours is when you still have viable cardiac tissue. Okay, but sometimes you may still have ongoing ischemia to show that there is still a possibility of viable cardiac tissue. So it's a bit, you still have to apply clinical judgment, okay? But then that is a threshold. So PCI is your mainstay treatment, okay? If you can have PCI, percutaneous coronary intervention, within 90 minutes, you must go for it, okay? In ST elevation myocardial infarction mostly. All right, what is PCI? PCI is basically a catheter, so a flexible tube, okay, with a balloon at the tip, all right, which is inserted either through the radial artery or the femoral artery, all right, and it's threaded to the site of occlusion, which you would have identified using coronary angiogram. All right, so it's threaded to the site of occlusion, and then the balloon is inflated. All right, and what it does is that it pushes the plaque against the wall, against the vessel wall. All right, and then a stent is placed basically to keep the vessel patent. All right, and then you take out the tube and whatnot. All right. Now, if you can't offer PCI within 90 minutes, it is said that you must give fibrinolysis, okay, within that 90 to 120 minutes, all right? Fibrinolysis being alteplase, tenecteplase, and retaplase, not and, or retaplase, okay? In the case of multi-vessel disease, you can't, it's not ideal to, place multiple stents. So you typically go for a coronary artery bypass graft if there's no contraindication, all right? So, and fibrinolysis, we don't give in non-ST elevation, acute coronary syndrome. So, as I said, single or double vessel disease, you typically go for a PCI. And if it's a triple vessel disease, you go for a coronary artery bypass graft, a CABG, unless it's contraindicated. Secondary prevention. So discharging the patients, you have to place them on a high dose statin. What's that going to do? It's going to stabilize the plaque. Remember, again, we talked about the atherosclerotic plaque, which is formed mostly from cholesterol deposits. So you want to stabilize that plaque to reduce the chance of recurrence. Okay. ACE inhibitors reduce the cardiac hypertrophy and cardiac remodeling. Okay. Hence, it's reducing complications, and it also reduces the afterload, okay? Beta blockers is very important in the management of acute coronary syndrome. Even from the start, you give this from the onset, because in the first 24 hours of a myocardial infarction, the patient is at risk of ventricular arrhythmias, and beta blockers would really help to prevent that, okay? So, and controlling the blood pressure and whatnot. So, lifestyle modifications. You want to advise these patients to stop smoking. As I mentioned earlier, smoking has a prothrombotic effect. Okay, so the patient stopping smoking is going to make a drastic change. Dietary changes, low cholesterol diet, exercise. There are cardiac rehabilitation programs now, and counseling, educating the patient on the importance of being compliant with their medication. This is very crucial, because sometimes patients may underestimate the importance of these medications, or once they feel better, they feel they need to stop. You need to tell them that some treatments, like the aspirin, it's lifelong, okay? And they need to just keep taking them. Okay, so we're going to go further into complications now. With thrombolytic therapy, one of the most frequent complications that may arise is bleeding. You could have bleeding either at the puncture sites or just spontaneously. One of our major concerns is cerebrovascular accidents. Patient may suffer a hemorrhagic stroke. Risk factors include the elderly frail patients with significant comorbidities, patients with uncontrolled hypertension. Okay, this increases their risk of strokes, hemorrhagic strokes, quite greatly. And patients who are concurrently on other anticoagulants as well. All right, they might present with a GI bleed as well, a gastrointestinal bleed. Yeah, you might have other adverse effects like allergic reactions, hypotensions, reperfusion arrhythmias, and the likes. So let's talk about retroperitoneal hematoma. As I said, during catheterization, when undergoing the PCI, there could be a puncture to the vessel, all right, which will lead to extravasation of blood into the peritoneum, okay? Now, you notice that the patient becomes hypotensive and they rapidly go into hypovolemic or hemorrhagic shock. On physical examination, you might notice that they have either palpable groin hematoma or they have flank pain, okay? If they're in shock already, you would notice that they are pale, they have cold extremities, the pulse is thready, there might be a hemoglobin drop as well. A CT angiogram would reveal the site of the extravasation, okay, and the site of the leak. You want to initiate a massive transfusion protocol in this case, all right, and if the patient is on any anticoagulation, if they're on heparin, you want to do a reversal. So you'd give protamine sulfate. If they're on warfarin, you want to give vitamin K, okay? And then coil embolization, because you want to stop the bleed, all right? Because the transfusion will replace the blood. You'd stop the coagulative effect, the anticoagulative effect, but then you need to stop the site of the bleed. Okay. So post-MI pericarditis, We have peri-infarction pericarditis. This occurs 1 to 3 days after the myocardial event. And this is in response to the inflammatory changes. And you can have Dressler syndrome, which happens as more of a autoimmune pericarditis, and this happens 2 weeks to months after the myocardial injury. Okay, with pericarditis would present with a pleuritic chest pain. Pleuritic chest pain is a chest pain on inspiration. Okay, so when the patient takes a deep breath, they're going to feel this sharp pain in their chest. It's worse when they're laying down, and it gets better when they lean forward. The patient might also say that it radiates to their trapezius, okay, or their like scapula. They may have a low-grade fever. On ECG, you would see diffuse ST elevations. Now, this differs from the ECG of a myocardial infarction, because myocardial infarction would be in territories, but in pericarditis, you're going to have saddle ST elevations in every lead, okay? So it's diffuse, it's everywhere. And another important thing is that the cardiac enzyme troponin would be normal, all right? And you'd have signs of more of an inflammatory picture. So you have an elevated erythrocyte sedimentation rate, and you'd have leukocytosis. Management for pericarditis is high-dose aspirin and NSAIDs. Now, aspirin and NSAIDs are very irritant to the stomach, okay, to the stomach lining. So you want to protect them with a proton pump inhibitor, and you also have to give that with omeprazole, okay? Colchicine is also used in the treatment of pericarditis as well. So reinfarction can occur. Reinfarction is basically having an MI again, all right? If it's a type 1 MI, which is caused by a clot, PCI is your mainstay of treatment. And if it's a type 2 MI, which is more of a demand or ischemia, this you can address with beta blockers and nitrates. All right, so there's papillary muscle rupture. Papillary muscle rupture, this usually occurs in either an inferior MI or a posterior MI. So in this case, the papillary muscles, when there's infarction to the papillary muscles, it's going to make the chorda tendineae, which is attached to them, quite loose, all right? And that's going to affect the leaflets, the mitral valve leaflets, all right? So they wouldn't shut tightly as they should. So they're going to collapse, all right? And that's going to cause mitral regurgitation. Now, you're going to hear a holosystolic murmur, which is usually at the apex or the left axilla. The patient, because of the mitral regurgitation, the patient may experience pulmonary edema, okay, and dyspnea. And treatment here is surgery, okay, and mitral valve replacement. Free wall rupture and ventricular septal rupture. These are more insidious events, okay? They happen secondary to a weak granulation tissue. In free wall rupture, this is the rupture of a free wall of the ventricle, okay? That means blood is going to extravasate or into the pericardium, and this can cause cardiac tamponade, and the patient can go into shock. With free wall rupture, you need to do emergent pericardiocentesis, okay, and surgical repair. Ventricular septal rupture, on the other hand, this is more sudden. The patient would rapidly deteriorate in this sense because there's a rupture in the interventricular septum, and that creates a communication between the left and the right ventricles. And there's going to be a mixture of deoxygenated blood and oxygenated blood. So that's going to cause hypoxemia. Patient is going to get cyanotic very quickly, and that can cause sudden death. All right. All right. And our last complication is the left ventricular pseudoaneurysm. Okay, this usually happens, say, weeks later after a myocardial infarction. This is, we know what an aneurysm is. There's going to be an abnormal bulging because the ventricular wall is now weak. So there'll be an abnormal bulging of that weakened ventricular wall. Okay. Patients would have chest pain, persistent ST elevation for weeks. And because of that blood that tends to go through that pocket, all right, there could be stasis. And we know varicose striae, which talks about, for thrombosis, which talks about endothelial injury, stasis, and a hypocoagulable states. So here we have endothelial injury and we have stasis, and that can cause a thrombus to form and an emboli as well. So an emboli can go into the cerebrovascular system and cause a cerebrovascular accident. The patient might have a stroke. All right. So the treatment here is a surgical repair. Okay, so if anybody has any questions, you can put it in the comment section and we can address. Otherwise, I believe that's the end of the presentation.
Thank you so much.